Assalamualaikum everyone. We are Group 5 and today we will be presenting a real-world case study on tuberculosis, a disease that despite centuries of effort continues to be a significant global health challenge. Before we dive in, allow me to introduce our team members. Myself, Sarah Batrisha binti Ibrahim, metric number 2410508, Siti Khairunisa binti Khairul Azmi, metric number 2418740, Putri Nofana Aimuni binti Khairil, metric number 2410044, and Sharifah Jamila Khairin binti Said Shukri Nizam, metric number 2411374. Each of us has contributed to bringing you this presentation today. Let us begin with the background of the outbreak. The disease we are focusing on is tuberculosis, commonly known as TB. When we talk about the location of TB outbreaks, it's truly global. TB is present in every country, but certain regions bear a disproportionately higher burden. As stated on the slide, in 2023, the WHO Southeast Asia region accounted for a staggering 45% of new global TB cases, followed by the African region with 24% and the Western Pacific region at 17%. This highlights the concentrated nature of the disease in certain parts of the world. Regarding the time frame, TB is not a new disease. It has affected humanity for millennia. However, it continues to be a persistent health crisis in the modern era. The global statistics were quite sobering. An estimated 10.8 million new TB cases were reported worldwide in 2023 alone. This figure underscores that TB is a very much ongoing challenge, not just a historical one. Moving on to how TB outbreaks are detected, it involves a systematic approach combining clinical and laboratory methods. Firstly, clinical suspicion is crucial. This means screening individuals who present with persistent symptoms that suggest TB, such as a chronic cough, fever, night sweats, and unexplained weight loss. And chest x-rays are essential for identifying lung abnormalities, particularly in symptomatic individuals. Finally, at a public health level, surveillance and data analysis are paramount. Routine surveillance data, combined with statistical analysis, helps public health authorities to identify clusters of cases and unusual patterns, which can signal the emergence of a new outbreak or an increase in existing transmission. Let us move into the epidemiological profile of tuberculosis. The primary causative agent is the bacterium Mycobacterium tuberculosis. Its mode of transmission is primarily airborne. This means that it spreads through the air when a person with active pulmonary TB coughs, sneezes, or speaks, releasing tiny droplet nuclei that contain the bacteria. These can then be inhaled by others. Regarding the timeline, the incubation period for developing active TB after infection can range from a few weeks up to 2 years, though most develop a latent infection first. Only about 5 to 10% of those with latent TB will progress to active disease. For the contagious period, a person with active TB is contagious when they are actively coughing and spreading the bacteria. However, with proper treatment, a patient usually becomes non-contagious within 2 to 3 weeks. It's important to remember that individuals with latent TB infection are not contagious. Now, let's identify who was affected. While TB can affect anyone, certain groups are at higher risk. These include individuals with weakened immune systems, such as those with HIV, diabetes, or malnutrition. People living in crowded or poorly ventilated conditions are also highly vulnerable due to easier transmission. Other high-risk groups include healthcare workers due to occupational exposure, the elderly and very young children who have less robust immune systems, and individuals who use tobacco or excessive alcohol. Lastly, TB disproportionately affects communities facing low socioeconomic status, where factors like poverty and limited healthcare access contribute to its spread.
Hello everyone, my name is Putri Nofana Aimuni, metric number 2410044. Today, I will talk about the tuberculosis outbreaks, data and patterns around the world and how they affect public health. Understanding these outbreaks helps experts find better ways to prevent and control TB. Researchers studied 477 confirmed TB outbreaks over nearly 10 years. On average, each outbreak had about 5 cases, but some were much larger. In Greenland, more than 100 cases were linked to a single outbreak. London also faced a serious outbreak that lasted multiple years. Different TB strains were found in these outbreaks. The most common strain was lineage 4, also called the Euro-American strain, which caused 57% of cases. Lineage 2, the East Asian or Beijing strain, was responsible for 27% of outbreaks and is known to be linked to drug resistance. Drug resistance is a serious problem. While 64% of outbreak cases responded well to standard treatment, 28% showed some resistance and needed different medicines. 8% had made resistance, making treatment much harder. Outbreaks happen all over the world, but some regions were affected more than others. Europe reported the highest number of outbreaks at 37%. Asia had 21% and North America had 19%. Africa reported 13% of outbreaks, while South America recorded 6%. Australia had the lowest number with only 4% of outbreaks. Over the past 2 decades, TB cases have slowly decreased worldwide. Better testing, treatments, and prevention methods have helped control the disease. Even with this improvement, TB outbreaks still happen, especially in places with fewer healthcare resources. TB affects poorer countries more than wealthier ones. Africa and Southeast Asia have the highest number of TB cases because many people do not have easy access to hospital or medicine. Several problems make TB harder to control. People who have little education may not know how to protect themselves. Living in crowded conditions makes it easier for TB to spread. Many people in affected areas also struggle to get medical care, so the disease is often not treated early enough. To stop TB outbreaks, solutions need to focus on specific regions. Healthcare should be easier to access, people need more education about the disease, and living conditions must improve. Better housing, stronger healthcare system, and more disease awareness can help reduce TB in the long run. That's all from me. Thank you.
Now, I'll be presenting an overview of the public health response to tuberculosis. We'll explore how the global efforts to combat TB have evolved, starting with the core strategy that laid the foundation for modern TB control, the DOT strategy, followed by the more comprehensive Stop TB strategy. Let's begin with DOTS, which is Directly Observed Treatment Short Course. This was launched by the World Health Organization in the 1990s as a global response to the rising burden of TB. DOTS is widely recognized as one of the most cost-effective public health interventions. It focuses on 5 essential components, which are political commitment, case detection via sputum smear microscopy, standardized short-course chemotherapy, uninterrupted drug supply, and also monitoring and evaluation system. Together, these elements have helped reduce TB incidence in many countries and form the core of all modern TB control strategies. However, by the early 2000s, new challenges such as TB, HIV co-infection, drug-resistant TB, and health system weaknesses make it clear that DOTS alone wasn't enough. In 2006, WHO introduced the Stop TB strategy, building up upon the DOTS foundation but expanding its scope. This comprehensive approach includes 6 components, which is enhance DOT implementation, address TB, HIV, and MDR-TB, strengthen health systems, engage all care providers, empower people and communities, and lastly, promote research and innovation. This broader strategy reflects the complexity of TB control today, requiring not only medical solutions, but also strong health system and community engagement. So far, we have looked at the foundation of TB control through the DOT strategy and how
the Stop TB strategy built upon it to address emerging challenges. Now, let us explore how these global strategies were actually put into action, especially within the WHO European region, and what goals they aim to achieve. In the WHO European region, which includes 53 diverse countries, implementation required a tailored approach. After the fall of Soviet Union, TB re-emerged as a major threat due to weakened health system. In response, WHO prioritized support for high-burden countries. Key initiatives include the Plan to Stop TB in 18 high-priority countries and the Berlin Declaration 2007, which emphasized early diagnosis, improved treatment, and support for vulnerable populations. Importantly, countries were encouraged to address TB's social roots, such as poverty, stigma, and poor access to healthcare, recognizing that TB control is both a medical and social challenge. All of these efforts were directed toward ambitious but necessary global targets. Aligned with the Millennium Development Goals, the Stop TB strategy aimed to halt and reverse the TB epidemic by 2015. Specific goals included reducing TB prevalence and death by 50% compared to 1990 levels. The long-term vision is to eliminate TB as a public health problem by 2050, defined as a fewer than one case per million people. Achieving this target requires sustained political commitment, universal access to care, and continued research and innovation.
Thank you, Sister Nisa, for your amazing presentation just now. Hi everyone, good to see you again today. I am Sharifah Jamila Karim Binti Sashki Nizam, the last presenter for today's presentation. As for my part, let's explore on how tuberculosis prevention strategies are linked to different levels of disease prevention, namely the primordial, primary, secondary, and also tertiary levels. Now, we begin with the primordial prevention first. These levels aims to prevent the emergence of risk factors themselves. In the context of TB, these involve educating communities about the TB transmission, reducing the stigma, and promoting early health-seeking behaviors. For example, the WHO advocates for targeted health education initiatives to support effective prevention strategies. Next is primary prevention, which focuses on preventing the onset of the disease. One key intervention is vaccination, which is the Bacilli calmette guerin, or also known as BCG vaccine, which administered primarily to children to protect against severe forms of TB. Continuing with the primary prevention in healthcare settings, using PPE, which is the personal protective equipment such as N95 mask, is vital to protect the frontline workers from exposure. Alongside this, hygiene campaigns can encourage proper respiratory etiquette, and this tissue disposal help reduce transmission in communities. Moving on to the secondary prevention, we aim to detect and address the TB early. This includes early testing and screening, especially among high-risk groups like household contacts of TB patients. Contact tracing also plays a crucial role by identifying and treating undiagnosed cases, which prevents the spread of latent infections. Finally, we move on to the last levels of prevention, which is tertiary preventions. It involves minimizing the long-term impact of TB. For patients with post-TB lung disease, long-term care and rehabilitation, including breathing exercise and pulmonary therapy, are essential to restore lung function and improve quality of life. To conclude our presentation for today, I want to emphasize certain key elements. This tuberculosis outbreak analysis highlights the importance of a structured, multi-level approach in responding to the infectious disease. We reviewed the outbreak's background, detection, transmission patterns, and key affected groups. By connecting our public health actions like quarantine, awareness, and contact tracing to various prevention levels, we can see how laid strategies can effectively manage current outbreaks and prepare us for future ones. Last but not least, a multi-level prevention approach is essential in fighting against tuberculosis due to its complex and multifactorial nature of the disease. Each level plays a specific role, which primordial prevention can reduce social and environmental risk. Primary prevention stops infection through measures like vaccination and hygiene. Secondary prevention ensures early detection and treatment. And lastly, tertiary preventions help manage complications and support recovery. By combining all of these levels, we can prevent better the spread of TB, reduce its impacts on individuals and communities, and move closer to ending the disease. These are the references that we use in completing our real-world case study on infectious disease, which is tuberculosis. I think that's all from us for today. Thank you for listening and see you again.